Hi, I'm Dr. Paul Smith from Bangor OBGYN. Welcome to my educational module regarding induction of labor. Induction of labor is a hot topic in OB because that particular technique is a tremendous satisfier for many women and many physicians because it places him or her in the same place at the same time with the patient and lets that clinical team be together at the time the baby arrives. Different from spontaneous labor. So let me talk about what the factors are that are involved in induction of labor so that you can have some knowledge about how that process is reviewed with you and your provider. There are two general categories of induction of labor. Indicated and elective. Now, elective means healthy mom, healthy baby. The cervix generally has to be favorable, and we are anticipating inducing contractions and a vaginal birth. So let me leave that for just a moment, and let me talk about some indications for induction of labor. Medical indications are the usual category that is involved in this indicated group. Sometimes toxemia or preeclampsia. Preeclampsia, toxemia of pregnancy, elevated blood pressure, protein in the urine. That disease of pregnancy is becoming severe enough to say, hey, let's put the baby in the warmer and let's end that process. Maternal disease such as IUGR, intrauterine growth restriction, related to either a condition for the baby or a medical condition in the mother, high blood pressure or something else, that is causing the baby to grow slowly and interfering with transfer of oxygen and nutrition across the placenta. So growth restriction can cause a reason for indicated induction. Sometimes the mother has a medical condition, seizure disorder that is uncontrolled and the baby would be safer out. Sometimes there is a condition with too much water in the uterus called polyhydramnios that causes compromise of the baby's environment, and the baby would do better out than in. So these types of things, and sometimes it's simply because the cervix is so far dilated that there's a hazard that this baby will fall out before you get to the hospital. And so the cervix can sometimes cause an indication to say, hey, let's deliver that baby in a controlled situation before a woman goes into labor remote from the hospital. There are a number of indicated reasons. This is just a few of them. Indicated inductions always take priority over elective inductions. And elective means healthy, baby is head first, and we want to go ahead and bring that baby out in a safe condition. There are some requirements for an elective induction. The baby has to be 39 weeks gestation, 1 week before the due date. This is a hard line in the sand that has been established by standard of practice now, and it is virtually impossible to justify intervening before 1 week in advance of the due date. So that 39-week boundary is a very hard boundary that needs to be observed for baby's safety. We look for a favorable cervix. Now, what does favorable cervix mean? Well, I have on my website a spot that talks about the 4 jobs the cervix has: thin, soften, dilate, and swing, from pointing toward the baby's tailbone, or toward the mom's tailbone, to pointing down the birth canal. So if the cervix is not starting to thin, soften, dilate, and swing, then the body is giving me clues that this cervix is not ready, and induction may be less successful. Waiting for a favorable cervix is an important feature of successful induction. The literature shows very clearly that inducing labor with a favorable cervix can lower the C-section rate. And that's contrary to a lot of the urban legends that are out there. Say, whoa, if you induce, it raises the C-section rate. Well, if the cervix is not favorable. And I sometimes tell my moms who say, wow, I'm ready to get this over with. Your cervix is not favorable. And if I induce labor, I will raise your risk for a C-section. And I can't do that. So 39 weeks, favorable cervix, and the baby has to be head first. All those things are safety features that are designed to allow for a successful vaginal birth. So if these things fall into place, then your provider may call Eastern Maine Medical Center and make an appointment for an induction. And there are several slots available each day relating to how many nursing staff are on duty, how many can be safely accommodated. Safety drives the ball game. And an appointment can be made for induction. Now, elective inductions, the appointments are always a soft entity. If someone becomes indicated, elective will be bumped. Medically indicated always has priority. So whenever a provider might say to you, I might say to you, okay, let's deliver your baby next Tuesday, that's a guess, not a contract. So keep that in mind as you alert family members and people plan on traveling and arriving for the delivery day. Once the availability of a bed in labor and delivery is established, the nursing staff will call you in, start an IV, start oxytocin, and the process of induction will go. And I, or one of my colleagues, will discuss with you how that process goes once you get your foot in the door. But when we look at elective induction of labor, it is a tool that I use for my patients to successfully manage that pregnancy and have a happy outcome. After all those visits in the clinic, I hate to miss the main event. And so from my perspective, elective inductions that put me in the delivery room with my patients when the baby comes out are a tremendous satisfier for my patients and me. I hope I've given you some information with which you can discuss induction of labor with your physician or with me in the upcoming weeks. And as always, these considerations are evaluated in the context of you, your baby, your medical condition, and that's best decided with your provider. So thanks for being with me, and I hope you've enjoyed my discussion about induction of labor.